Good afternoon. It's indeed a privilege to be here today. What a beautiful day, a wonderful conference, and we are here next to where Mahatma Gandhi had a prayer meeting in June 1927, and we are here to draw inspiration from him when he said that a man forever will remain imperfect, but it will be within him to seek perfection. And what we are trying to do is draw inspiration from his words to seek perfection in healthcare, to see how is it that we can improve the care that we deliver 24/7, 365 days. Could I have the slides, please? I'd like to thank the amazing organizing team, Dr. Saadullah, Alex, Vijay, Dr. Gyani, and the CAHO leadership for organizing this wonderful conference and for the invitation to really spend a few minutes talking about quality beyond accreditation. So all of us really want patients like this, don't we? That's what keeps us excited if we can actually walk in and have patients behave like this. So in our quest to have patients like this, many of us have tried different tools, different techniques. Some of us have looked at ISO, and we all know that ISO is really about standardization, but it isn't anything to do with healthcare. So many of us started looking at accreditation, and we know that there are numerous accreditation systems in the globe, and different countries have different systems, and sometimes within the same country there's more than one system. So we at Apollo did a search about 11 years ago on what would be the best system, and we zeroed in on, at that point in time, Joint Commission International, which is regarded by many as the gold standards. And of course, Joint Commission keeps evolving, and at that point in time, this is from last year, we have 323 standards and 1196 measurable elements. So in 2005, our first hospital got accredited. It was at that point in time the 6th in Asia, the first in India, and then Chennai and Hyderabad became the first stroke accredited program in the world, and then we took accreditation to Ludhiana, Dhaka, and Bangalore, Kolkata, and Mauritius. And about that same time, Dr. Gyani started working on NABH, and we were really happy that there was going to be an Indian system. And I recollect fondly the first few meetings that actually took place in our boardroom at Apollo Hospital, Delhi, on how we can develop an Indian standard. And so we started the journey of NABH with our hospital in Madurai, and then the Apollo Specialty Hospital in Chennai, and now, of course, we have 14 hospitals that are accredited by NABH, and many more are going to be accredited in the coming months. What does accreditation bring to an institution? Collective responsibility, a realization that we are as strong as our weakest link. It brings in efficiency, at least we hope it does, and for many institutions, it does. There are so many distractions in life. There are many, many distractions in hospitals as well, and we hope that accreditation gets us focusing on patient safety. It brings in accountability, and one would hope that that accountability starts with the CEO and not the housekeeping staff. We pride ourselves in the way we communicate. My doctor recommends a glass of red wine every day. Accreditation helps us focus on proper communication. And for those who like to stand out, accreditation helps you stand out. Talking about standing out, do you recognize this gentleman? Prince, right? Prince amazed the world in the mid-80s by saying the world had changed, I don't need a name. So from now on, I will not be referred to as Prince, but I will be nameless, and I will be referred by this symbol. So his agents, the album, the media went into a tizzy. How could Prince not have a name? How can you call someone with a name, replace that with a symbol? So the media then decided to call him TAFCAP, the artist formerly known as Prince. The way healthcare is evolving today, we will soon have TIFCAP, the individual formerly known as patient, now as a partner. Now all of us, try and figure out what our partner wants, right? So there was this fantastic movie called What Women Want, and that was really trying to understand what can make a woman happy. So we asked ourselves this question at Apollo: what will make all the stakeholders happy? So what do patients want? They want three things. They want good clinical outcomes, they want value for money, which is becoming increasingly important, and they want service quality. Let's not deny that. That is important. What do physicians want? Well, they want good clinical outcomes. They want their patient to say, wow, I had a great experience, so they can tell everyone else about what a wonderful doctor, what a wonderful hospital, so they get to see more patients. And of course, they want a conducive milieu so that they're able to practice freely what they are committed to or what they're trained for. What does insurance want? They want good clinical outcomes, they want to pay out less for every claim, and they want to retain their customers. So if you actually look back, what is the common thread? The common thread is good clinical outcomes. So we decided that we will start focusing on outcomes, and we developed a clinical balance scorecard. And there are lots of scorecards that we have that talk about investment, that talk about finance, that talk about profit and loss, but this was unique that it only talked about clinical outcomes. We looked at 25 parameters that we believe were very important. We put this on the Apollo Lighthouse platform, which is our internet-based learning platform. We looked at international benchmarks, which was the world's best published outcomes. So we looked at different institutions and we got one parameter from one institution, one from another, and these had to be the best published outcomes. To give you an example, the best published outcomes on bypass surgery are from Cleveland. Their inpatient mortality rate is 0.6%. So if any of our hospitals has a mortality rate of more than 2%, they get a score of 0 on 4. But if it's less than 0.8, they get a score of 4 on 4. And that's how the scoring system develops. 1 year survival rate for liver transplants. We did 1,540 liver and kidney transplants last year. But it's not about volumes, it's about survival, because that's really what patients are interested in. So our benchmark there is Mayo, that has the best outcomes. So if we meet the benchmark for Mayo, you get a score of 4 on 4, but if you lose more, then you actually have a score of 0.4. Catheter-related bloodstream infections and a whole lot of other parameters on infection, we benchmark with NHSN. So what we get at the end of this score is a total score of 100. We want each of our hospitals to be in the green zone, which is more than 75. And believe me, it's really tough because these are the world's best published outcomes. So if we do a cabbage in Bilaspur, which is really rural, or it's done in Chennai, the outcomes have to be the same or we will not do it. 50 to 75 is the yellow zone or the orange zone where we are worried, and we don't want any of our hospitals to be in the red zone, because if they're in the red zone, then of course they have to send us an action taken report on how they'll make sure that the score doesn't fall back into the red zone. So this is data that we get. This is data from each of our hospitals, and you can see there are some in the orange. Thank God there was none in the red. And of course, there will be hospitals that will go from green to orange and go from orange to green. This is data for all the parameters from one of our hospitals. And because we rely so heavily on data, we have an audit system where we do unannounced audits to make sure that we look at the raw data to see that the data that is put on the Lighthouse platform is actually accurate. How hard was it to actually get this off the ground? It was really hard because this was something very novel, this was something very new, and it really was banging your head against the wall. But we were able to sustain it. We started off with 6 hospitals, expanded it to 25, then took it to 32, and then at 42. We make sure that there is a leadership review every month, and the reports go to the board every quarter. We've linked the medical head and the CEO's appraisal to clinical outcomes, and that's really novel, and that really means that the entire organization, not just the doctors and nurses, are focused on outcomes. We've started giving out awards. We give out the ACE awards for the highest score each year for hospitals based on their bed size and categories. And after 2 years of reporting, we decided that we needed to upgrade it because we wanted it to be competitive. So we've got the spirit of constantly wanting to improve, and we constantly change the benchmarks in terms of improving them or enhancing and making them more stringent. So has it made an impact? Well, it has. And I just want to draw your attention that 4 is the best score. So if we look at ALOS post angioplasty, yes, there were months when we had a score of 3, and then again we had 4, and then it dropped down. Catheter-related bloodstream infections, in a particular hospital, the scores fell, and there was corrective action taken, and then the score improved. Urea reduction ratio in patients on hemodialysis to see how effective hemodialysis is. Average length of stay post TKR. Because if the length of stay is short, we know that there have been no complications. It's been a good recovery, no pain, good mobilization. Complication rate post-coronary intervention. And again, there are variations, and then we get to where we want to be. And overall, when we started, the score was at around 72, and consistently over a period of time, it's gone up for the group. And that really has been the biggest learning for us, is that, you know, this is a journey that takes time, but you have to be constantly at it. We've now gone on and developed the Apollo standards for clinical care. So beyond ACE at 25, we have another dashboard that really looks at our COEs that contribute about 60% to our workload. We have the critical policies plans. We have the incident reporting system, and nurses are very familiar with all the incidents that they constantly have to face. We have the quality program that looks at the patient safety goals, and every single mortality is reviewed. And all this comes into a number which is very visual. It's very easy for non-medical people also to understand. What have we learned? What we've learned is that one actually has to have an open mind and reach out to colleagues. And sometimes the smaller hospitals come out with suggestions that are really valuable for the entire group, and that's something we learned. We also learned that sometimes to get the job done, you really have to work as a team, because you really can't do this alone. And if you want to climb higher, you really have to rely on the support of other team members. I'll stop here, and I'd like to extend a very warm welcome to all of you to join us at the International Patient Safety Congress and Transforming Health Through IT, the twin conferences that we run in every year. And this year it's going to be in Chennai, 21st and 22nd October. Last year we'd actually held it in this venue and had 1,500 people from 20 countries. Lots of opportunities for you to present your work, posters, oral presentation, and win a lot of awards. So looking forward to seeing you in Chennai. Thank you.